Welcome to Best of the Day from the 14th International Myeloma Workshop in Kyoto, Japan. I'm Dr. Sagar Lonial, and today I'm joined with Professor Kenneth Anderson from the Dana-Farber Cancer Institute.
Good to be here.
And we're going to talk about induction therapies today and some of the data that was presented at the meeting. So let's start off with, I think, one of the biggest controversies or questions in myeloma today, and that is if and when in terms of high-dose therapy and transplantation.
Right. So this is, has been and is a very exciting international workshop. What is really most important in the transplant realm is that novel therapies often combined when incorporated as induction therapy and then as consolidation therapy to increase the depth and the duration of the response, and then as a maintenance, novel therapies there too, have clearly changed the outcome. The whole paradigm of transplant has changed and the outcome is markedly improved for the better. So as your question implies, now we have the happy problem of determining who needs transplant and who doesn't. Transplant is clearly a standard of care in the appropriate patients, but we are having such good outcomes now with combinations of targeted therapies that one can ask, is transplant necessary in everyone? So for example, one of the new proteasome inhibitors, carfilzomib, it's the more potent proteasome inhibitor of the same class as, or of the same target, the chymotryptic site of the proteasome as bortezomib. So carfilzomib has been combined with lenalidomide dexamethasone, and a couple of trials were presented here. Andrzej Jakubowiak spoke of that, and Ola Langren from the National Cancer Institute also used that regimen even in very earlier or smoldering myeloma patients. But suffice it to say, if you use this more potent proteasome inhibitor with lenalidomide dex, you get very high complete response rates, including molecular complete responses. So there it brings up the question, if you have a molecular complete response after this induction, is the transplant really necessary? So already we have, and these studies were updated at our international workshop, already we have trials that are in a randomized fashion asking whether transplant is necessary or not. 3 that were mentioned at this meeting I'll just quickly mention. One was just to update folks on the French and the multi-site in America trial. That particular trial is lenalidomide, bortezomib, dexamethasone induction, followed by a randomization to transplant or not, and then in either arm, lenalidomide maintenance. And we don't have data yet on that, but it's fully accrued in France and accruing rapidly now in the United States, so very exciting data there. A second trial that again is it's completely enrolled is the Antonio Palumbo trial, where lenalidomide dexamethasone is used as induction, and the randomization thereafter is to melphalan, prednisone, lenalidomide oral therapy versus 2 transplants, with again a randomization in either arm to lenalidomide maintenance or not. And that particular trial is fully accrued. So far has shown response rates to be equivalent, progression-free survival to be more favorable in the transplant arm, and a trend, but not yet significant, for survival in the transplant arm versus the lower dose cohort. And finally, today, in one of the abstracts just presented, the Italians again talked about a randomized trial. They are very rapidly completing these trials of lenalidomide dexamethasone induction, and then the randomization thereafter was to Cytoxan, lenalidomide, dexamethasone versus 2 transplants with high-dose melphalan. And in this instance, there was a randomization to Cytoxan, lenalidomide prednisone or lenalidomide maintenance in each arm. And that trial, again, isn't mature, but what it has shown so far is, again, the response rates are equivalent whether you get the CRD or the Cytoxan lenalidomide dex, or you get the high-dose melphalan. The progression-free survival, again, is more favorable in the high-dose transplant cohort, but the overall survival is not different.
Yeah, and I think, you know, these trials, I think, are important because in the United States, I think many oncologists have sort of taken the tack that a CR is a CR and it doesn't matter how you get there. And clearly from these studies that have completed so far, that's not necessarily the case. And I think one of the ways that one can address that question is through MRD analysis. And I know the English did a trial where they looked at that in detail. We talked about it a little bit in my session yesterday as well. And that was presented today as well, right?
Yeah, so that would be Professor Tony Childs and the MRC9 trial. It was really 2,000 patients in the United Kingdom treated with induction therapy. And as part of that trial, they also evaluated different bisphosphonates, either intravenous zoledronic acid or oral chlordronic acid, and showed the former to be superior. But in any event, what was presented at our workshop is the data on about 1,000 of those patients who received high-dose therapy and transplant, and what thereafter did receive thalidomide maintenance in at least a cohort of those patients. And as you've mentioned, a significant fraction of those patients achieved minimal residual disease, as assessed in this instance by multi-flow flow cytometry staining. And so Professor Childs showed very nicely that that achievement of minimal residual disease did portend a better progression-free and overall survival. I just would mention the other excitement in induction here was this issue of achieving minimal residual disease. How do we best measure it? Should we use multi-flow cytometry? Should it be 4-color, 7-color staining? What about polymerase chain reaction for the immunoglobulin gene arrangement characteristic of the patients? And further enhancing the stringency of response, of molecular response, if you will, even further by using or incorporating PET-CT scanning.
Right.
And so that's very exciting on the one hand. The other area that we might mention in the induction treatment is, since we have such active regimens that we use to treat active myeloma, these are now being moved earlier in the disease course to smoldering myeloma, patients who wouldn't need therapy otherwise. And there were two wonderful presentations. You may have covered these already, but one from Dr. Mateos in Spain, and one today by Dr. Ola Langren from the National Cancer Institute. The former, the randomized trial in Spain, showed that using this very lenalidomide and dexamethasone up front could delay progression of smoldering to active myeloma, and actually even extend, obviously progression-free, but also overall survival. And Dr. Langren, with the carfilzomib lenalidomide dexamethasone, showed the majority of patients, albeit it was only 10 patients, but 8 of them got a molecular complete response, including improvements as assessed by flow cytometry, PCR, and by PET-CT scanning. So I think we're getting more and more potent regimens, and we're starting to think about using these combinations even earlier.
Well, I think the Spanish trial is certainly worth spending just a moment or two on, because I think that could have real implications for how we design trials going forward. That was a trial where high-risk smoldering was defined slightly differently than I think we do in the U.S. And I think what I was really struck by in that analysis was not that the Len-Dex arm did well, because I think that's not a surprise, but it was really how poorly the control arm did, the no treatment arm. And there seemed to be a very high one-year mortality associated with being in the observation arm. And while the PFS certainly was very interesting, that seemed to be a little bit, at least to my interpretation, a little bit higher.
Right. I think one thing that characterizes this workshop, and it is wonderful, it's a small world in the myeloma area, and we are not shy about being active in our debates and in our discussion. And as you bring up here, there's differences between the American way, the National Cancer Institute that derived from the Mayo Clinic, and our friends at Salamanca, Spain, in terms of how to define high-risk smoldering multiple myeloma. And the same patients were actually analyzed by both systems in one of our panel discussions yesterday, and there were different outcomes.
Right.
But your question implies, and I think is right on, that some of the patients, really the control arm, as you correctly said, had a much poorer outcome than you would expect for patients to have smoldering myeloma. Nonetheless, the principle of being able to do this, it's going to allow us now to better study and redefine perhaps what we call myeloma, earlier stages myeloma. There was concept of myeloma versus metastatic myeloma, which would be a more active, widespread, later stage disease. So by no means was there evidence presented here that we should be treating smoldering multiple myeloma patients, certainly outside of the context of a clinical trial, but nonetheless using active combinations early, to me, is very exciting, because that's the way cancer has been cured. With leukemias, lymphomas, Hodgkin's disease, testicular cancer. Now we need to do this in myeloma.
Right, right. All right, so let's get back to the transplant studies. I think we've talked about most of the ones that were presented there, and I think at least my interpretation of the take-home message really was that it's too soon to throw transplant out yet. And what Professor Cabo said a couple of days ago when he was discussing consolidation and maintenance was really the idea that the novel agents don't replace transplant, they enhance the efficacy of transplant. And I think that that's an important consideration.
Absolutely. They've changed the transplant paradigm. I think what's incorporated into all of these clinical trials now, which is wonderful, is the assessment of very stringent responses, including molecular complete responses, because the response that you achieve with a transplant may or may not be the same as the response that you achieve with combination targeted treatments without a transplant. So yes, right now the standard of care is a transplant, albeit with novel therapy incorporated in before consolidation and after the transplant.
Right, right. And I think, I know yesterday in a session, I think Paul Richardson presented some data in his debate about early versus late transplant that Jay Nuka from our place had actually put together as well, looking at early versus late. And if you choose your patients correctly, you probably can wait, at least in the absence of randomized data. But that's a very selective group of patients that we offer delayed to in our center. So you're right, I think the jury's still out about how to do that. So let's then switch just a bit to older patients. What are some of the findings that you found interesting in the older patient series?
Yeah, well, just as in the transplant patients, so for the elderly, the incorporation, honestly, of novel agents, whether they be thalidomide or lenalidomide with induction or as maintenance, or whether they be bortezomib as induction or as maintenance, together with melphalan and prednisone, has in each instance the novel therapy with melphalan and prednisone in many studies shown superior outcome compared to melphalan and prednisone alone. And so that has set the stage now for testing the next generation of novel agents together with melphalan and prednisone as the initial treatment for newly diagnosed elderly patients. So in particular, there's an ongoing clinical trial now of carfilzomib, the second generation more potent proteasome inhibitor, together with melphalan and prednisone, actually versus Velcade melphalan and prednisone, ongoing in Europe for new drug approval in that population. There was no data available yet to present that, but it shows that we're extending that concept a little bit more. In terms of induction therapies for the elderly, Dr. Thierry Facon from France just discussed today in a panel outcome, that in spite of the incorporation of novel therapies for elderly patients, they really haven't enjoyed the advantage that our more younger transplant patients had. So he was making the case for oral therapies that are better tolerated and they can have a much more favorable side effect profile, and that therefore might be better tolerated in the elderly population. He, in his discussion today, talked about the fit elderly patient and the frail elderly patient and how we can distinguish those and maybe treat them differently. But in that spirit, I did want to just quickly mention that we're excited in the U.S. and around the world in that when we get novel second-generation proteasome inhibitors, we have now 2 of them, one called ixazomib, and a second that's a little further behind in development called aprozomib. But in any event, these oral proteasome inhibitors have already been combined with lenalidomide dexamethasone. And there was experience presented at this meeting several times on the lenalidomide dexamethasone ixazomib proteasome inhibitor. That's a very well tolerated proteasome inhibitor. You only take it once or twice a week. The response rates are very high. And so this concept of an all-oral induction regimen, which has proteasome inhibitor and lenalidomide in it, is a real possibility. And perhaps I think of it now in the elderly population because it may be indeed much better tolerated there. But Dr. Facon really did stress, and it is very true, that we still need to try to improve the outcome of our elderly patients. The other point I would make is that the lenalidomide maintenance that's used in this population after induction has really extended, certainly progression-free survival. And we have the opportunity now to examine one of these oral proteasome inhibitors. In fact, ixazomib is being tested as a maintenance, as not only in induction but in maintenance as well. So I think that our elderly patients are going to enjoy the advantages of novel therapies as well.
Yeah, I mean, I think one of the areas I've always struggled with is the eligible versus ineligible definition that's given to us, which from the European perspective is 65. And I know at our centers there isn't necessarily an age cutoff for suitability for transplant. And so I think of Dr. Facon's idea of frail versus fit elderly patient. I think that really is I think of 3 sets of patients: the young patient that clearly is transplantable, the older patient that is fit and I think is transplantable as well, and then the frail, where I'm not sure, and I'd like to hear what you think about this, I'm not sure they need melphalan. I'm not sure melphalan is the answer for those patients, and perhaps doublets with less toxicity, particularly oral, might really be the answer for those patients instead of VMP or MPT or MPR.
No, you're absolutely right. You know, there's a trial that you and I both know well. We've been hearing about it for years. But we don't have data. It was mentioned here again at the workshop, but I think of it now because it's melphalan, prednisone, thalidomide, a melphalan-containing triplet, versus lenalidomide dexamethasone in this same population, newly diagnosed non-transplant candidates. And it was discussed by Dr. Facon again today. We're expecting to have data available later on this year, perhaps at the time of the American Society of Hematology. But suffice it to say, we have good data on long-term lenalidomide dexamethasone therapy, and it is quite tolerated. So hopefully that may offer the opportunity in the elderly population where they could take these novel agents long enough to enjoy progression-free and overall survival advantage. We'll see.
Yeah, no, I think that makes sense. And I guess the way I sort of think about it is for the younger patients, you're willing to accept toxicity in order to try and achieve a major response because you know that's usually correlated with long-term outcomes. In the frail patient population, toxicity becomes a little bit more challenging.
It does. It does. I think You know, my thought would be that over time, I do think we're going to evolve towards novel therapies. And the other issue there, that's predicated upon avoiding some of the low blood counts and other things that are incumbent with melphalan, for example, and the potential risk of secondary cancers with these alkylating agents. But I also think as we use the more potent second-generation agents, you know, even in the elderly patients, we're going to be able to get significant responses, maybe even molecular complete responses there. So, and I think the other important point, Dr. Kyle mentioned this in his talk, is, you know, as we get to the elderly patients, we have the non-myeloma competing causes of death, right? Their lifespan is obviously not as long as some of our younger patients for other reasons, cardiac disease or hypertension, diabetes, other comorbidities, so that we do need to be aware of we're treating patients who are perhaps not in the same performance status or with the same reserve. You know, Terry Facon called them frail, but even if the patients aren't frail, they often have comorbidities that may
they age quicker,
influence the way we treat them.
Right.
So.
Absolutely. No, I mean, I think it is certainly it's an exciting time to have access to all these drugs and these new treatments that are helping us, I think, to change that natural history curve even further than we already have so far.
Yes. No, I think, you know, the message in this meeting was not only are we using the first generation of novel agents better, we're using the second generation of novel agents now, not only in relapse refractory disease, but as newly in induction treatment. And excitingly, these agents are also providing a maintenance strategy. We also heard, which we won't talk about here today, but even though we have first and second generation novel agents, there are many new classes of agents coming along. So the patients who are treated very well with induction will clearly enjoy more long-term benefit than ever, but that may very well be extended because we have novel, completely novel classes, antibodies, as you know well, and many others coming that are looking very, very positive in myeloma that's relapsed. Yeah.
No, I think it is. It's never fun to deal with this stuff, but I think it's certainly exciting and gives us more hope for prolonging survival.
Absolutely.
All right. Well, thank you.
Pleasure to be here.
All right. Well, thank you for joining us for this series of Best of the Day at the 14th International Myeloma Workshop. We look forward to seeing you on further series of the Best of the Day. Thank you.